Hi, my name is Emily. I'm a family nurse practitioner student, and I'm here to do a respiratory assessment on you today. I'm going to first assess to see if you are in any respiratory distress as you're breathing normally. And I'm going to do that by assessing to see whether or not you are using any accessory muscles as you breathe. I'm looking to see if you're using your sternocleidomastoid muscle, or your scalene muscle, or your supraclavicular muscles, none of which you are using as you breathe. I'm also going to assess your rate and rhythm of your breaths. I'm going to do that by using the clock on the wall with a second hand as I place my hand on your posterior thorax and count for 15 seconds. So just breathe normally. All right, your respiratory rate is about 14 breaths a minute, which is not labored, and your rhythm is also regular, and there's no accessory muscles being used. I'm going to now assess your trachea to see if there's any deviation or if it's midline. I'm going to do that by palpating your sternal notch, and then placing my hands on either side of your trachea, and there is no deviation. Your trachea is midline. I'm also going to assess your fingernails for any discoloration, particularly cyanosis or any clubbing, which could indicate poor ventilation. I'm also assessing your anterior thorax for any signs of deformities or bruising, and I'm going to look around at your posterior thorax as well and assess for any bruising or deformities, none of which I can find. I'm going to now assess your anterior, posterior to lateral diameter. So if you'll raise your arm up for me, I'm going to place my hands on your anterior, posterior thorax, and then come around over here to your lateral thorax. And your lateral to anterior, posterior diameter is approximately 2 to 1, which does not indicate any kind of barrel chestedness. Now I'm going to come around to the back side of you and assess your posterior chest. Turn that. I'm going to start by assessing for any deformities or tenderness that I can palpate with my hands. So you let me know if any of this palpation is painful for you. Is that any of that hurt?
No.
Right. No tenderness or deformities are noted. I'm going to now assess for tactile fremitus, and what I'm going to do is lay my hands again on your posterior thorax and have you say 99, 99, 99. And I'm going to make sure that I can palpate the vibrations equally and bilaterally on both sides of your lung field. So go ahead.
99, 99, 99, 99,
Okay,
99.
good. I felt the vibrations bilaterally and equally. Now I'm going to test for chest excursion. I'm going to do that by finding approximately the 10th rib space. I'm going to move your bra up a little bit, and placing my thumbs on either side of your spine and my hands cupped around your anterior, posterior thorax. And go ahead and just breathe normally as I watch the divergence of my thumbs. Good. My thumbs move about 2 centimeters, which is a normal chest excursion. Now I'm going to begin by percussing your chest, listening for either resonant or dull sound, which indicates how much air is within your lung cavity. I'm doing this in a ladder formation. It's a resonant sound. tongue down here, I'm moving into a dull sound when I'm coming into contact with your diaphragm. Now I'm going to test for diaphragmatic excursion. And to do that, I'm going to have you take a exhale, a big exhale, and keep it out as I percuss for a dull sound. Okay, I'm going to mark this spot. You can breathe normal. Okay, now I'm going to have you inhale and hold your breath as I percuss again. Okay, I'm going to mark this spot here. Now I'm going to measure with my measuring tape. And that is approximately 3 centimeters. Normal diaphragmatic excursion is 3 to 5.5 centimeters, so that is within normal limits. Now I'm going to auscultate your lung sounds. As you're breathing, normally I do not hear any wheezing or adventitious breath sounds just without the stethoscope, so now I'm going to see if I can hear them with auscultation. I'm going to again listen in the ladder formation. Just breathe normally. Okay, take big deep breaths. Okay. Just going to move your brow a little bit. Good. Good. Vesicular breath sounds are noted. They are equal, a little bit diminished in the bases. I'm going to have you, to further assess if there's any consolidation in your lungs, I'm going to do some voice assessments with you. The first one is bronchophony, and I'm going to have you say 99, 99 like you did earlier. This time I'm going to auscultate with my stethoscope. Okay, go ahead.
99, 99, 99, 99, 99, 99, 99, 99, 99.
Okay, good. The 99 is muffled, but that's good because I do not want to hear it clearly because that would indicate consolidation. The second voice test I'm going to perform is egonophy, and that is where I want you to say E, 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 and I'm going to listen to see if the E turns into an A sound at the end. Okay, go ahead.
E, 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 E.
Okay, good. The E sound stays along E and does not turn into an A, which indicates no consolidation. The last is pectoriloquy, and that is where I want you to whisper 1, 2, 3, 1, 2, 3. And I'm going to listen to see if I can hear that. Go ahead and whisper. All right, very good. I could barely hear the whispering, which is an indication that there is no consolidation there. If I could hear it clearly, that would indicate that there's some sort of consolidation. That concludes our respiratory assessment. Your rate is rhythm. Your rate is regular. You are not using any accessory muscles. I hear soft vesicular breath sounds with no adventitious breath sounds. Thank you very much.
You're welcome.